Viewers, welcome to the Facebook Live session. On the occasion of World Diabetes Day, today our topic for discussion is obesity and diabetes. And for our discussion, we have with us Dr. R.N. Mehrotra, Senior Consultant, Endocrinologist and Diabetologist at Apollo Hospital, Jubilee Hills, Hyderabad. Dr. R.N. Mehrotra has an experience of over 28 years. He has done his MD in General Medicine at Motilal Nehru Medical College and DNB and Endocrinology, Metabolism and Diabetes at Sanjay Gandhi Postgraduate Institute of Medical Sciences. He is diligently working on his clinical research on diabetes, osteoporosis, and metabolic bone disease. He provides services related to diabetes management, endocrine disorders, diabetes mellitus, etc. Welcome, doctor, to our Facebook Live session.
Good afternoon, everybody.
So, doctors, starting with our questions, so what is your message to our audience on this World Diabetes Day?
See, if you look at the theme of this year for the IDF, is basically the patient should have more access to education. We know that the education of patients will have an impact on the monitoring, on their glycemic control, and the looking at their complication.
So, doctor, what is your message to our audience on World Diabetes Day?
See, if you look at the theme of the IDF for this year, that is basically the more access of education to the diabetic patients. We know that if a patient is educated and is basically taught about the monitoring and looking for complications and foot care and hypoglycemia, the outcomes are better. He has less chance of getting hypoglycemia, less chance of getting a diabetic foot, and better chance of getting a good glycemic control.
So, doctor, are diabetes and obesity the same, or are there any interlink between them?
Yeah, if you look at the population, wherever we find the obesity is increasing, you will follow that the diabetes prevalence also is increasing. They basically both are linked together. And if you look at the population now, we see that our Indian children are becoming more obese and they are leading to more obese adults. And we are finding more and more the diabetes in the population. It's not only in our country, you look at any other population. The Western developed world also had the same kind of issues. Their population became more obese and they had more chance of getting diabetes.
So, doctor, how commonly does diabetes affect people with obesity?
See, it's quite common. If you look at the maybe I would say more than 2 times the risk of factor of diabetes getting increased in case the population is obese. It's not only the obesity as such. It has to link it to the lifestyle, to genetic factors, and that is an important part also.
So, doctor, generally, how does obesity increase the risk of diabetes?
Now, if you look at the obesity, basically mean more fat cells in the body. And the fat cells basically make some inflammatory mediators or some kind of hormones which will decrease the insulin effect on the cell. That means the insulin will not be able to control the sugars. The cell will need more and more insulin to control the glucose values. That means pancreas has to work more harder, and that sometimes will lead to the failure of pancreas. So coupled with that, the insulin resistance and the progressive beta cell damage, you get more and more chances of getting diabetes.
So, doctor, why does obesity cause insulin resistance?
As I said, the obesity basically means for fat cells, and those mediators we look at basically are more the IL-6 or they have more effect on the insulin effect, and that means the machinery has to work harder to produce the glucose values, to control the glucose values.
So, coming towards our next question. In the Indian population, diabetes is more common in which age group?
If you look at the comparison of the Western and the Indian population, we are getting a diabetes at maybe say a decade earlier, and the Indian population basically more kind of a special population. We are not so much high BMI is not there, but we have more visceral adiposity. That means our waist circumference is more as compared to the similar BMI people from the Caucasian population. So we have more insulin resistance. Coupled with that, our beta cell functions are not very great. We do have some factors which impact the beta cell function. So coupled with that, we get the more chance of getting diabetes.
So, doctor, what are the reasons for the rise of diabetes patients in India, especially in the mild age group?
The one is basically the visceral adiposity, as I said, that makes it much more insulin resistant. And second, if you look at the habits of exercise from population point of view, we not get exercisers. If you look at hardly 10 to 15% people will be doing exercise. You look at a diet plan, we have basically more of carb intake, we have more saturated fats. So sedentary life habits, the poor dietary habits, and coupled with the genetic factors from before, will lead to more diabetes in our population.
So, doctor, are there any latest advances in the treatment and management of diabetes?
See, the world of diabetes care has been advancing rapidly over a period of 2 decades. There have been advancements in diagnosis, and we have advancement in monitoring of the patient. We have newer kind of meters, we have newer kind of CGMS monitors, we have newer kind of insulin which are there. The newer insulin which are there basically are more stable. They have lesser variability. Coupled with that, we have the newer advancement in the oral drugs as well as the injectable drugs. We have drugs now which can control the weight as well as the diabetes part. We have the injectable drugs like GLP-1 which have been known to control the weight and again the sugar part. Plus we have the drugs like SGLT2 inhibitors. Now these drugs not only control the sugars, they decrease the risk of your cardiovascular disease, they decrease the risk of kidney disease, heart failure and cerebral stroke, and increase the mortality, decrease the mortality in the long run.
So, doctor, what is the difference between insulin pumps and connected CGM insulin pumps?
See, insulin pump, if you look at, basically are the devices basically which will drive the insulin into your body in a slow rate, and there are two kinds of rate which we have. One is the basal rate, which will be always there 24 hours, and then we have the rates with the when it comes with the meal, they're called the bolus rates. So we have the two kinds of insulin there. Now, in the open pump, what we call as the open loop pump, the patient has to check the sugars and has to feed how much carbohydrate the patient is going to take, and depending upon the bolus is decided. In the CGMS connected pump, what we call as the newer pump or the artificial pancreas system, if the pump is connected to the sensor, now sensor will send the signal of the blood sugar values to the pump, and provided they have the proper algorithm, the pump will decide how much insulin to be pumped in. So basically the dependency upon the patient's monitoring is kind of done away with. If the sugars are coming down, the insulin rate will come down, or if particular threshold value is reached, it will stop giving the insulin. Again, when the sugar starts to rise, the insulin will start to getting pumped in, and in case the sugars are rising up, there will be a correction value. So basically the system, what we normally do, we check sugar and make a decision. That factor is taken away, and that makes control much more easier and much more stable.
So, doctor, what are the benefits of continuous glucose monitors over others?
See, there are 3 to 4 ways of monitoring your glucose. One is by what we do is the lab monitoring, where we check only a fasting plasma glucose and a post-meal plasma glucose. We anticipate that the particular day what patient has eaten, taken the medicine, is same as what he has been doing in last couple of months. Other than that, we can check in the home. Patient can check in the home the fasting post-meal values, or what we call as basically a 7-point monitoring, the fasting, 2 hours post-meal, in all the 3 meals in a day, and a bedtime values. Coupled with that, now even that causes sometimes the peaks may be missed out, or when the patient is going down, it can be missed out by the glucose by finger monitoring. CGMS basically monitor your glucose for 24 hours in a day, and each and every spike of glucose is taken care of, and it's basically seen in the monitoring system. Even the lower downs can be easily picked up on the CGM monitoring. Coupled with that, the patient has maintained his intact food and injection diary. We can interpret this reports to see why the sugars are going down and going up, and how to modify the treatment so that patient can get a better treatment.
So, coming towards our audience question. So, doctor, do diabetes smartphone apps helps in managing diabetes?
Yes, definitely they help. One basically if you look at the smart apps that are available on the phone, one is the diet. They tell you about the carb intake in the diet and how you should modify it. That is quite helpful. Second, they remind you of the medication. Third, you can basically even monitor your sugar values and keep a good glucose chart on them, which is easy. The doctor can also read that chart to see how to modify the medication. The last part basically is the insulin dose adjustment. Now we have apps which can at least tell you how to adjust your basal doses, so that you need not visit the hospital every week to get the dose adjustment. You can do the adjustment in the home much more confidently and get a better glycemic control in a shorter duration of time without getting hypoglycemia.
So, doctor, is intermittent fasting safe for people with diabetes?
Now basically intermittent fasting basically means the patient is not going to be eating for a long duration of time, and the carb intake will be less. Now, it is good strategy to lose weight. So sometimes we do tell our patients of obesity diabetes to use intermittent fasting. But the word of caution is that somebody is on a simple treatment like metformin, DP4 inhibitor or AGD inhibitors, they can do intermittent fasting and fine with it. But if somebody is on multiple subcutaneous injection of insulin, or if somebody is taking sulfonylureas, those drugs will have to be modified and adapted according to the diet plan and then taken care of. So I would say that if patient is already having the insulins or sulfonylureas, they should contact their doctors before they go on to a decision of intermittent fasting.
So, doctor, how can obesity and diabetes be prevented?
Now, as we see that basically obesity means preventing the children from getting obese. Look at their lifestyle. Now, look at our school habits. Now, how many children play in the school? How much time they have been spending in front of the TV or mobile phones or laptops? I know the COVID has been bad for everybody. The people do have gained weight in that. But if you have a healthy child, he will grow into a healthy adult and will have lesser amount of cardiovascular disease. So, main thing is to prevent the obesity in the children so that we have healthy adults. If we have less obesity, we have decreased insulin resistance, we have a lesser chance of getting a hypertension and dyslipidemia than cardiovascular disease, and lesser chance of a progressive diabetes.
So, doctor, is it normal for a diabetic patient to have abnormal sweating or excessive sweating?
Abnormal sweating depends upon the blood sugar value. Sometimes somebody is having a long-standing duration of diabetes, and when they are eating food, they may have some sweat on the forehead. It is not really a sign of hypoglycemia. It is called a gustatory sweating or could be an autonomic sweating. Sometimes when the sugars are going down, when the patient is going into a sign of hypoglycemia, the sweating may be a sign of hypoglycemia. So that time definitely the patient should check the sugars, check the blood pressure and act accordingly.
So, doctor, how long can a diabetic patient can go without insulin?
It basically has been a kind of thought that at some stage of life of diabetic patients they will require insulin. But if you have been managing your diabetes well and you've been able to keep your the weight under control and keep your waist under control, then you can delay the use of insulin for a long time. I really cannot say yet because the insulin depends upon a lot of things. It depends upon the patient beta cell function also, which may have some genetic factors included into that. So, not all the patients may be able to exclude the insulin, but majority of the patients will require late starting of insulin, and lesser amount of insulin is not only the insulin which is harm for the body. If the insulin is not used properly, that is the problem. We will be able to use the insulin and get better control even without getting hypoglycemia.
So, doctor, how can a diabetic patient boost their energy?
I would say boost energy is from the energy source will come from the exercise. Exercise is a very, very important part. Maintain your calorie intake, maintain your protein intake and do regular exercise. That will definitely boost your energy.
So, doctor, is it safe for a diabetic patient to do excessive exercise?
Not excessive exercise. When somebody has been sedentary for a long time or obese, we start them into an exercise plan very gradually. We really don't go into an exercise plan quite rapidly into it. So what we say is start gradually and build up gradually, and in case you have any features of baseline cardiovascular disease, so better consult the cardiologist before you start an exercise program. If somebody has a diabetic foot problem, look at the footwear, look at the foot callosity, look at the foot ulcers, and then start the exercise program. If somebody is asthmatic, control the asthma well and then go for it. Somebody is having very high sugars and very low sugars, they should not start the exercise. So exercise is a good thing to do, but it should be started very gradually and should be monitored very quite carefully.
Doctor, at what sugar level is insulin actually required?
See, I would say if you look at the indications of insulin in type 2 diabetes, one of the very important indicators is a type 1 diabetic. They will require insulin from the very first day and they will be on insulin throughout their life. Second is somebody is pregnant. Definitely, normally the best drug to use in pregnancy in diabetes is the insulin. Third, when somebody is going for a surgery or somebody is having serious infection like diabetic foot or pneumonia, definitely they have to go on to insulin at that point of time. Or somebody has been using oral drugs and when the doctors feel that the drugs have reached a threshold value where we cannot increase the drugs further to get the sugar control, then the insulin is initiated.
So doctor, what are the dietary habits that needs to be followed by a diabetic patient?
See, if you look at the diabetes disease, it's a disease of carbohydrate metabolism. That means body needs insulin to metabolize the glucose. So in case the main factor is to limit the carbohydrate intake. I'm not saying make it zero, like in some diet fat which are there. We say to give the adequate calories and we'll give a balanced diet. Maybe carbs can be kept say around less than 40 to 50%. Some part has to come through protein. Protein is a very, very important bodybuilding molecule which are important from the muscle point of view. If somebody is not taking adequate protein, he will feel very weak and very tired. The fats also important, but the fat has to be seen what kind of fat we are giving you and how much fat is being consumed. So basically, it's a balanced diet of carbohydrates, protein, and fats, and the essential fatty acids and minerals. Both have to be balanced around in a balanced diet.
So, doctor, your
See, diabetes is a disease which has been increasing. If you look at the prevalence of diabetes, has been increasing in every population. Specifically in our country, we are getting diabetes at an earlier age. So, main thing is to prevent diabetes doing regular exercise. Let not our children be obese. In case we have somebody has a family history, somebody is obese, we should be checking diabetes at a maybe screening for diabetes at an early age so that pick them early and treat them better. What we mean by treat them better is to get the A1Cs down to the target values so that if the A1Cs are controlled, the long-term complications are prevented. If somebody has the complications, we should get it screened and get them treated. The main thing is to pick up early, treat early, and have a good glycemic control.
So coming towards our last question, doctor, could you please tell our audience about the facilities provided at Apollo Hospital, Jubilee Hills, Hyderabad?
See, Apollo has a very integrated program. We have a Apollo Sugar Clinic, which basically has clinicians there. We have a backup of nutritionists. We have backup of health educators. We can evaluate for all the complications. We have the cardiology backup. We have nephrology backup. In case somebody requires a foot care or if we have podiatry backup. In case somebody requires a vascular surgery, it can be done. If somebody requires the cardiology, so basically it's the integrated care of not only focusing on the sugar, we're looking at the patient as a whole, the sugar values as well as the patient other complications which can be attended to, and providing the education. That is very, very important part.
So dear viewers, we have come to the end of our session and hope we have covered all aspects. If you still have more doubts, you can book an appointment with Dr. R.N. Mehrotra and clarify your doubts. Thank you, doctor, for educating our audience in today's session.
Thank you.
Thank you for joining us. Stay tuned for more such educative live sessions. Namaste. Namaste viewers. Welcome to the